Great, thanks, Chris. So I think it's interesting to push for a standard of care from a trial that showed that the adequacy of the surgery was woefully inadequate. The McDonald trial, more than half of patients had less than a D1 resection. So many argue that the use of radiation is really making up for bad surgery. So I think the question here is, with good surgery, what are the failure patterns in gastric cancer, and does radiation contribute anything to this? And I'm the first one to argue for combined chemotherapy and radiation in GE junction cancers, but the STAL trial, which is a positive trial, really is in GE junction cancers. And I'm going to focus the debate on gastric cancer, different disease. So the AJCC staging for gastric cancer was recently updated and changed. We now subgroup patients by node number. And you can see from this slide that once you get above a T3 stage or any node positivity, and this is a survival database in over 13,000 patients treated in the West, survival falls below 40%. And most of the patients that we see are going to be node positive, so the results with surgery alone in the US for survival are fairly poor. So these are the options we have for adjuvant treatment in gastric cancer. And the good news is that adjuvant therapy does improve survival. We do have the McDonald approach. This was the first positive adjuvant trial giving 5-FU, leucovorin, and radiation, and a very modest 10% improvement in survival, which is held up in multiple follow-ups. But then a more contemporary study without radiation, pre- and post-operative chemotherapy using the MAGIC trial and the MAGIC approach, and most of the patients on this study had distal gastric cancer, very similar survival results without radiation. And then chemotherapy alone has made a comeback if you do good surgery. It's to me, I really had to kind of fight and spill blood to get this into the NCCN guidelines. But it's kind of hard to argue with two trials treating 2,000 patients, all of whom had D2 resection and no radiation, a year of oral 5-FU, 10%, and then okay, we don't have S1 in the US, it's a magic pill in Japan, Xelox, capecitabine oxaliplatin for 6 months also gives us a 10% improvement in survival. So very similar survival benefits for chemotherapy alone versus adding radiation. And again, we'll look at the quality of the surgery and the local failure patterns for the McDonald study, which you don't see in these more contemporary studies where better surgery was performed. So here are the local failure patterns after surgery and adjuvant treatment. So the McDonald trial, as Chris correctly stated, 10% had a D2 resection. And this is really the acceptable academic standard globally now for surgery. So 90% of the patients on this study had inadequate surgery. And the local failure rate was 30%. 5-FU and radiation reduced it to 19%. And this was the only thing that improved survival on this study, was reducing local recurrence. So what about Cunningham's MAGIC study? Okay, now 40% had a D2 resection. The local failure rate with surgery alone was 21%. That's the same as McDonald. So no radiation, no chemo, same survival as McDonald, and you actually did get some local reduction with chemotherapy alone. So now let's get to the Japanese, where everybody gets a D2 resection. On the S1 trial, this is a year of oral 5-FU, the local failure rates were 3% versus 2%. Another Korean study, this is 6 months of capecitabine oxaliplatin, 100% D2 resection, surgery alone 10%. It was reduced a little bit with chemotherapy, but to me it's kind of hard to argue here. What's the role of radiation when you get local failure rates that are this low? And even the MAGIC trial, 20%. So what about distant recurrence? Did the McDonald approach have any impact on distant recurrence? Actually, it did not. A little bit of a delta for peritoneal recurrence with radiation, but actually distant recurrences were higher on the radiation arm. So you can't argue that the McDonald approach reduced hematogenous metastasis. It was actually 15% rate higher in the radiation arm compared to the chemo arm. The MAGIC trial, you got distant recurrence reduction of 13%. On the S1 trial, it was about 6%. And on the classic trial, Xelox, it was about 10%. So chemotherapy did reduce distant recurrence in all of these studies except the McDonald trial. So the McDonald trial, you could argue the benefits were driven by really, really bad surgery. So does radiation add to D2 resection? Chris did quote the results of the ARTIST trial. This is a randomized trial of D2 resected gastric cancer patients, randomized to get 6 months of capecitabine platinum with a sandwich approach of capecitabine platinum with the addition of radiation. He didn't show you this curve. No difference in distant disease-free survival and no difference in overall survival. So in the study as designed, there was no difference with the addition of radiation. Now there was a planned subset analysis of lymph node negative disease and lymph node positive disease. And there was a whopping 4% difference in disease-free survival with the addition of radiation. So if I wanted to treat 96 patients and have 4 benefit, then I think I would add radiation after a D2 resection. They also interestingly saw that intestinal versus diffuse did get a benefit for radiation. But this is hypothesis generating, and now ARTIST-2 is going to do a trial in intestinal node-positive patients. But outside of a study, would I give patients radiation with a D2 resection? The data argue it doesn't help. So what is the role of radiation in the adjuvant treatment of gastric cancer? I think the extent of surgery dictates the need for radiation. We get much higher rates of local recurrence with less than a D1, D2 resection. And I agree, Chris. You know, if I had my gastric surgery in a community hospital by a surgeon that does 5 gastrectomies a year, and he did less than a D1 resection, and of the 8 lymph nodes sampled, 3 were positive, then I would give that patient 5-FU and radiation. However, the ARTIST, in a setting of a D2 resection, argues for no clear benefit for postoperative radiation added to adjuvant chemotherapy, and I think it adds weight to the use of perioperative or postoperative chemotherapy alone. Now, esophagus and GE junction cancers are a different animal. These are diseases that extend above the GE junction. They're not peritonealized. Margins are an issue. And I agree for esophagus and GE junction cancers that chemotherapy alone achieves mixed results and that combined chemoradiation trends superior, but our debate today is not about GE junction cancers, it's about gastric cancer. And again, we talked about the ongoing trials that hopefully will add clarity to this. The critics trial, everybody gets preoperative chemotherapy. Unfortunately, they only mandated a D1 resection, but postoperatively, patients get randomized to chemo alone, with or without radiation. This is a 750-patient trial that's being run in the Netherlands and Sweden, and I think is near accrual. And then the preoperative question is being looked at in both esophageal and gastric cancer in the ongoing TROG trial, which is going to be conducted in Australia, European centers, and Canada. The pilot phase is finishing, and this will be also a 750-patient trial. And then the ARTIST-2 trial, this is the trial that showed no benefit for radiation and D2 resection. It's going to take that small subgroup that had that whopping 4% benefit and is going to randomize them to chemotherapy alone with or without radiation in node-positive disease. So I think to summarize, local recurrences are higher when less than a D2 resection is performed. Chemotherapy and radiation in the US intergroup trial improved outcome, but only by reducing local recurrence. It had no impact on distant disease. Trials with better surgery, chemo alone achieves a benefit without radiation, including the European MAGIC approach, as well as the Asian approach of S1 and Xelox after D2 resection. RT in a D2 resection, the ARTIST trial did not show an improvement in either disease-free or overall survival, but perhaps a very small benefit in node-positive and intestinal histology patients. Thanks very much. I guess we'll vote.